session to evaluate ocular surface damage and tear function test in patients with hypothyroidism, and control. Thank you, sir. Good afternoon, everyone. Next. We all know what is dry eye syndrome. It need no introduction. Just for the sake of people, I'm saying it's an ocular discomfort leading to blurring of vision, burning, itchiness, redness, grittiness in the eye. We all are aware of dry eyes present in hyperthyroid cases. Now there are studies which also say that dry eyes are present in hypothyroid. So in this study, I aim to evaluate the presence of dry eyes in both hypothyroidism, and control. So aims and objectives to evaluate and compare tear function tests, that is Schirmer's test, tear breakup time, OSDI, and ocular surface characteristics in patients with recently diagnosed cases of hypothyroidism, and control. It was a clinic-based prospective study conducted in Mahatma Gandhi Medical College Hospital, Jaipur, for a period of 15 months. All my patients were recently diagnosed within 2 to 3 months of the active diagnosis of thyroid. They were chosen and they were all aged between 20 and 65 years. They were excluded if they had any other ocular surface disorder, glaucoma, tropical or systemic medical usage prior to examination, contact lens, and all written consent was taken. Now evaluation of tear function test, there was OSDI, ocular surface disease index. I need not go into detail of these things, it's all general. So Schirmer's test, tear breakup time, and when to compare the ocular surface, I did the impression cytology. It was done from temporal interpalpable conjunctiva, and the grading was done according to Nelson's, and the staining was done by periodic acid shifts and hematoxylin. The Nelson's grading, there are 4 grades, and they are grade basis on the nucleocytoplasmic ratio and presence of goblet cells. The result, the statistic analysis is after the 70% of the newly diagnosed cases were females and 60% were hyperthyroid and 71 hypothyroid. The average age was 47 and 46. The important thing to note here, the BCVA proptosis and interpalpebral distance did not show any significant distance between the cases and control since they were recently diagnosed cases. So the OSDI scores in control, if we come to it, was 29. In hyperthyroid it was 42, and in hypothyroid it was 41. The Schirmer's test, it was 17.6 in controls, 12.9 in hyperthyroid, 13.3 in hypothyroid. The tear breakup time was 11.15 in control, hyperthyroid 7.18, and note please, the hypothyroid had more damage in tear film. It was 6.38 seconds. The impression cytology showed significant squamous metaplasia in cases of hyperthyroid and hypothyroid. So the mean Schirmer test score was decreased, tear breakup was reduced, and OSDI was increased, definitely suggesting dry eye was present. Grade 2 to 3 squamous metaplasia was also seen. Now proptosis and palpebral fissure height absolutely showed no difference between cases and control. Yes, dry eye was present. So definitely there was a question that there has to be a something alternative mechanism other than proptosis and increase in palpebral fissure height. So I studied, reviewed, and all I came to the ideology. There are 2 charts I want to show. The basic thing in hyperthyroid cases, there is the TSH receptors are located on lacrimal glands and orbital muscles. So with these antibodies, they attack the lacrimal glands, leading to decrease in tear function. The main culprit in every diagnosis in hypothyroid and hypothyroid is hyperosmolarity of tear film. Once tear film is hyperosmolar, there it stimulates a cascade of inflammatory cytokines like interleukins and MEP, and there is ocular surface inflammation leading to squamous metaplasia and loss of goblet cells. So in the hyperthyroid, we can see it clearly. There are 2 mechanisms. One, initially in the cities is due to antibody against lacrimal gland, but once it has increased, there is hypertrophy of orbital muscles, there is proptosis, eyelid retraction, so there is tear film evaporation. So in cases of hyperthyroid, we have dry eyes because of 2 reasons. In cases of hypothyroid, we have basically thyroid hormone is responsible for normal oxidative metabolism and free radical eradication. Or if it is deficiency, obviously there is oxidative stress and accumulation of free radical, leading to damage in lacrimal glands and ocular surface. Again, the same thing, hyperosmolarity comes into the scene. Obviously the stimulatory inflammatory cytokines and everything comes and leading to squamous metaplasia. So you see the thing, a dry eye, the end result is common. Both hyperthyroid and hypothyroid are dry eye, but the way to achieve it is different. So we conclude that association is more in thyroid patients as compared to control. The DRA and tear function test operational correlates. Dry eye in patients of thyroid function is attributed to ocular surface inflammation due to hyperosmolarity rather than tear film evaporation. So my recommendation is to routinely investigate all women of 30 to 50 years. We need to have proactive ocular surface dry eye evaluation, tear breakup time. We should refer them to surgeon, physician, endocrinologist, and once dry eye is definite, they require a proper treatment. Thank you.